Okay. So my talk today about aspirin role in cardiovascular disease. So I'll start with this picture. طبعا thank you very much for all attendees. We have attendees physically attending. We have attendees over the Facebook now, and we have attendees over the Zoom platform. يمكن هم exceeding يعني hundreds at the moment يعني. This is Ismailia. Welcome to all colleagues, all professors, all staff who are joining us for today. And let's go quickly. Patients with cardiovascular disease, they have so many cripples, and they are crippled by many problems: smokers, dyslipidemia, hypertension, diabetes, thrombosis. Some of them, like the patients with AF, my colleague has just illuminated an important role of NOACs on those patients with non-valvular AF. While I will talk about the role of acetyl salicylic acid in cardiovascular prevention. Just not to forget, this is the aim of ISMA, Ismailia Metabolic or Cardiometabolic Syndrome. Our mission to reduce the burden of cardiometabolic disease all over Egypt. Our goal to improve the practice of prevention and management of cardiometabolic disease. Our strategy is what we are doing now, continuous medical education, sharing experience, practice sessions, and our vision: together we do better. We have so many forms of cardiovascular disease, including coronary artery disease, atherosclerosis, hypertension, diabetes itself, peripheral arterial disease, and many of them ends by heart failure. And the risk, the lifetime risk of ischemic stroke, of thrombotic stroke, atherosclerosis, and coronary artery disease, peripheral arterial disease, angina, MI, is increasing with age and with the more burden and risk factors of cardiovascular disease. This is our enemy, atherosclerotic cardiovascular disease. You cannot imagine when it starts. The American in the Vietnam War has done some post-mortem studies in, mortal, even with age of 2 years, 3 years, 4 years, just for science. And they discovered some atheromatous plaques in children under age of 5 in Vietnamese. And this was associated with the very aggressive form of dyslipidemia, especially in the South Asians. So it starts very early. When you have familial dyslipidemia, whenever you have other risk factors, it might start maybe later. So it's very important that we fight this atherosclerotic cardiovascular disease with different medications to guard against atherothrombosis and atherosclerosis. We have many types of angina, unstable angina, stable coronary artery disease, myocardial infarction, STEMI and non-STEMI, and I'm not going to go through this. We have some TIA, we have RENT, reversible intermittent claudications, peripheral arterial disease, thrombosis. And if you see, as they said at 2020 and maybe before, that those are the most important medications in history of medicine. And one of them is acetyl salicylic acid. We have 3 important functions for acetyl salicylic acid. The initial one was as a painkiller, and this was at 1879, and with low dose at 1971 as anti-platelet effect of acetyl salicylic acid, and then at 1988 prevention of cancer colon. So our focus today is about the anti-platelet efficacy of acetyl salicylic acid. So low dose acetyl salicylic acid from randomized control trial. It goes without saying about secondary prevention of any atherosclerotic cardiovascular disease. The issue was for the primary prevention. هي دي المشكلة. Should we give patients acetyl salicylic acid or aspirin low dose 75 milligram or 100 milligram or 81 milligram like the Americans, they like this, for primary prevention or not. Actually, all initial studies, randomized control trials and literature suggested that it should be given for all persons above age of 40 maybe, even without risk factors for cardiovascular prevention. And after the new coming data, we have to personalize and tailor therapy according to patient's profile. This is how acetyl salicylic acid with high dose or with low dose they work. So with high dose, they work mainly on COX-2, so they prevent the prostaglandins which might initiate pain, while with low dose, they work on thromboxane E2, which prevents the cascade of coagulation and thrombosis. So this is why we give a small dose when we want to reduce the risk of thrombosis, while we give high dose as an anti-inflammatory and painkiller. Again, this is another reputation of the previous one with more details about high dose or low dose acetyl salicylic acid. Another effect of Asprotect or acetyl salicylic acid is its pleiotropic effect on nitric oxide production. They improve the release of nitric oxide from endothelial cells, and they improve the response of endothelial cells and vascular endothelium and vascular smooth muscle actually to the response of nitric oxide, leading to vasodilatation, which is very important in improvement of circulation. So it's very important that it's not only working by one mechanism, but there is another, we can tell, pleiotropic effect of acetyl salicylic acid. So it works as in harmony at the thromboxane E2 level to prevent its production, so it prevents thromboembolism. So it has many mechanisms of action: facilitation and the inhibition of platelet aggregation, protection of low density lipoprotein from oxidative modifications. As you all know, LDL itself is not an enemy, except if it is very high. It turns to very aggressive form when it is oxidized. And when it is oxidized, it sticks to the endothelium, preventing the endothelium from working, inducing endothelial dysfunction, and actually firing the cascade of atherosclerosis. So these are the different effects of acetyl salicylic acid, multiple mechanisms of action as you see here. So as primary prevention, most of the studies before the 3 trials that we'll discuss them shortly said that it's very important relative risk reduction in non-fatal MI and non-fatal stroke about 22 and 17% as primary prevention. As secondary prevention, as I said before, there is no second call for revising the effect of acetyl salicylic acid in patients with atherosclerotic cardiovascular disease as for secondary prevention. So the antithrombotic trialists collaboration, speaking about the acetyl salicylic acid and its antiplatelet efficacy in acute stroke, in previous stroke, acute myocardial infarction, and as I said before, there is no further talk about its role in secondary prevention. Again, it provides proportional reduction in serious vascular events by at least 25%, significantly reduction of mortality, overall mortality as secondary prevention. What about the GIT? When acetyl salicylic acid directly can cause some sort of GI upset, and indirectly by their mechanism of action, they might reduce the prostaglandin production, which is important for the GI mucosa. So the enteric coated tablet actually is tolerable and cannot actually lead to GI upset or GERD in patients receiving the enteric coated form of acetyl salicylic acid. Those 3 trials were discussing the role of acetyl salicylic acid in primary prevention, in aging population, in diabetics, and in patients with moderate cardiovascular risk. And they were all published around the same time, 2018, 2019. And in a mega, I would say, meta-analysis and review article, we cannot generalize their rules except when we tailor therapy for patients who needs primary prevention. So they didn't affect the guidelines dramatically. Still, according to the European Society of Cardiology, American College of Cardiology, and European Society of Cardiology, you can still give low-dose aspirin. Is well established for secondary prevention, and as regarding for primary prevention, especially in diabetics, it's for very high risk and high risk. For further details, we have to go here. So from 2016 to 2019, you can still give acetyl salicylic acid with low dose 75, 81, or 100 milligram as primary prevention. But how to tolerate this as primary prevention? That's what was explained by the American College of Cardiology. Patients with diabetes, it's important to consider whether they have high risk or very high risk. Most of diabetics, they will have any of those high risk or very high risk. If they are hypertensives, if they have dyslipidemic, smokers, atrial fibrillation, so they are at high risk or very high risk, so they will receive acetyl salicylic acid for primary prevention. Patients under age of 40, you should have the high risk criteria, which is the high elevated calcium score, which our colleague Dr. Islam explained in the early sessions. Elevated lipoprotein little a, dyslipidemia, especially familial dyslipidemia, strong family history of atherosclerotic cardiovascular disease. What about patients from the age of 40 to age of 70? For patients above age of 70, if they didn't have for all their life, they didn't have any single event, and you will give it for primary prevention, this is absolutely unjustifiable. Don't give aspirin or Asprotect for patients above age of 70 simply for primary prevention. This is illogic. What about between the age of 40 to 70? This is the very important. So if you have patients with low risk, you need to give, while patients at borderline, intermediate, or high risk, they should be given acetyl salicylic acid as primary prevention according to those scores. One of the most important score is CAC score or calcium score, which is actually not available for all patients because of the cost. However, if you have a patient who is a smoker, who have dyslipidemia, who have hypertension, so they have the risk factors which lead, you can give them acetyl salicylic acid for primary prevention. So the rule is still there for acetyl salicylic acid, and this is my take-home message. بحاول أكون ملتزم بالوقت اهوت يعني. Acetyl salicylic acid has different mechanisms of action: facilitation of inhibition of platelet aggregation, protection of low LDL from being oxidized, improvement of endothelial function by releasing more and more nitric oxide, and improvement of the response of the media of the medium-sized arteries to the response of nitric oxide, inhibition of proliferation of vascular smooth muscle, inhibition of inflammation, antioxidant properties, enhanced production of nitric oxide. If you see all those mechanisms of action, actually it's very important in prevention of atherosclerotic cardiovascular disease. And thank you very much, and I'm ready for 1 minute, 1.5 minute questions.
Thank you, Ahmed. It's a really good